Hello, good morning, good afternoon. It is a pleasure to welcome you to Epidemic Ethics Regional Seminar on the Americas. This seminar is the fourth in a new series spotlighting some of the complex and unique ethical challenges affecting specific regions of the world, both during and after COVID-19 pandemic. So, before starting and explaining how the panel will work, please, you have the direct questions to do the Q&A questions. Please send your questions over there. The Zoom will be used just to say hello. And before I continue explaining, please note that we have direct translation. So there you have how you can switch to the different translations. You will have translation in English, in Spanish, and Portuguese. And some of our speakers will speak in Portuguese, some will speak in English, and some in Spanish. So you will have to be changing if you don't know how to do it. We will leave a little bit the live interpretation screen so you can see that, where you can change there its note. But I want to just tell you, you can say hi using the Zoom, but questions, please send them to the Q&A function. And you can also like questions, so we can know which are the the questions you like the better. So please do that. And another important thing is that this seminar will also be recorded and available on the Epidemic Ethics website later in the week. And the seminar will also be live streamed on TGHN's Facebook page. So after saying all these more in-house things, let me explain you that this panel focuses on two big questions: looking back and asking our panelists what are the most significant lessons from COVID-19 global health emergency there was in the region. What are the unique experience of the region, and also looking forward, where does this region find itself presently in regard of pandemic prevention, preparedness, response, and recovery, and what ought to be the priorities for the pandemic prevention, preparedness, response, and recovery. So I am Florencia Luna. I'm director of the Bioethics program at FLACSO. I'm also superior researcher at CONICET. I'm also the chair of the Collaborating Center for PAHO and WHO. I've been in the steering committee of the Global Forum on Bioethics in Research for certain years, the president of the IAB, the International Association of Bioethics, and well, a long story, many ages working here. So that's not so interesting. Let me introduce our panelists. We will, as I was saying, this session will discuss the lessons learned from COVID-19 in the region. Many of them, let me remind you, are captured in the PAHO's publication, Catalyzing Ethical Research in Emergency, Ethics Guidance, Lessons Learned from COVID-19 Pandemic and Pending Agenda, to which all the members of this panel have contributed. So Sergio Surugi, who will be the first panelist, will focus on the ethics review of emergency research. But the lessons from the pandemic are not limited to research conducted in emergencies. So Sofía Salas, who will be our next speaker, will focus on the lessons and challenges that apply to all circumstances, including non-emergency research. Finally, we can say that the region of the Americas had the opportunity to implement some of the COVID lessons during the smallpox emergency. So that will be our third speaker's focus, Carla Saenz, Dr. Carla Saenz focus. So let me introduce Sergio Surugi from Brazil, Surugi de Siqueira. He has a doctorate in physiology from Pontifícia Católica University of Chile and has worked for 35 years as a professor of pathology, immunology, and bioethics at the Pontifícia Católica University of Paraná in Brazil. He served as a member of the National Research Ethics Commission of Brazil, the CNEP, for 10 years and is an external member of PAHO Research Ethics Committee. So welcome, Sergio. I will give you the CV of Sofía and then the one of Carla before they start. So I think you can remember each of them, and maybe you know all of them. They are quite well known in the region. So Sergio, you are very welcome to start.
Obrigado. Vamos compartilhar então a nossa apresentação aqui. Todos estão vendo?
Can you see my screen?
Yes, perfectly.
Sim, okay. Bom, primeiramente, muito obrigado pelo convite.
Well, first of all, thank you very much for this invitation to be here with friends and work colleagues in this event. As Florencia already mentioned, we're going to talk about lessons learned during the COVID-19 pandemic in emergency situations, health emergencies. The idea is to have swifter processes of ethical review so that research can be done quickly without losing the quality of the research. So we're going to talk a little bit about our Brazilian experience. I've been part of the so-called war room that was set up by CONEP, the National Research Ethics Commission. I'm going to talk a little bit about our experience and give some suggestions, make some suggestions, so that we can use these lessons in future situations of emergency. First, I have no conflict of interest in my presentation. That's my disclosure. Well, if we could summarize in very briefly all the initiatives that CONEP adopted early on in the pandemic, when we still had very few cases in Brazil. At the time, we did not yet understand the pandemic as a health emergency in Brazil, but I would summarize it in one word: agility. CONEP, this commission, the National Research Ethics Commission, we changed our regulatory flow. We wanted to look at potential research projects for COVID-19 that would come to the commission. We wanted them to be analyzed swiftly and with high quality. So there was a change in our flow. It's used to demand that research was analyzed first by a local committee, and then, if approved by the local committee, there was a demand for another approval by CONEP. So there were two processes of analysis and approval, and that delayed the process of assessment. So it used to take 60 days. In an emergency situation, of course, this is too long. So we changed the flow. Well, what did we do? Research projects on COVID-19 did not have to undergo the process with the internal committees. They went straight to CONEP, to the National Research Ethics Commission. So there was one single assessment. CONEP was very concerned with agility, as I said. And we called on meetings, daily meetings, to assess these projects. We also started allowing something new in Brazil. These meetings to analyze research protocols. We allowed these meetings to be conducted remotely. So we did not have to go through in-person meetings. So I would say this was the first major move, and we took it very early on in the pandemic, even before we received research protocols for that subject. Well, as a result, we started analyzing the protocols in 7 days and not in 60. And some protocols that were more urgent were analyzed in 72 hours. We also centralized the process in CONEP. That facilitated reaching standards for criteria. CONEP has experts from many different areas, and these experts met. And by doing that, we created standardized criteria to approve or disapprove research projects. Of course, we received many projects, and the number of projects increased very quickly. CONEP then could not analyze all the projects that were submitted in Brazil. And then we, once again, reviewed the norm. And then we were looking only at clinical trials for new therapies. As for other projects, they were then analyzed only by the institutional specific committees. But we didn't have to go through both committees as we did in the past. Just one of the committees had to look at the protocols.
You have 1 minute. You have one minute more.
Thank you. Okay. Bom, então, além disso, né, nós
also,
flexibilizar algumas regras,
we had to make some rules more flexible regarding informed consent. We also had some letters and documents talking about good clinical practices and the protocols, and also a plan for implementation of adverse events. So, as for the lessons learned, to finish, first, we learned that we could have a better flow. We improved our working flow. So, if there is a new emergency, we will adopt this new flow. Of course, also, number 2 is having a national research ethics entity that has distribution around the country and that can address this quickly. So it's important to first establishing national or nationwide rules and then considering local rules or local measures. Maybe this is the most important lesson we learned. Also, ordinary regulation should foresee the possibility of changes in emergency situations. Finally, the professionalization of personnel involved in ethics committees. This is critical. We cannot rely on volunteers, people sometimes that don't have ethics in the first place. In these situations, it takes a very strong commitment to ethics. That's why this professionalization is so important. I would like to mention that in an emergency situation, there are many unforeseen factors. So it's dangerous to adopt very strict rules that can hinder their execution. If we have unforeseen events, we need to be able to adjust the measures to the specific situation. So these rules, these basic rules, can minimize the impact of unforeseen situations. And learning from this adaptation process is very important. But we must know that oftentimes we need to analyze on a case-by-case basis. It is possible to conduct good ethical analysis in a short period of time. It is possible in a short period of time and with quality. Thank you very much, and sorry if I went over time.
Thank you very much, Sergio. If you can stop sharing your screen, that will be great. Meanwhile, I will introduce Sofía Salas. She's our second panelist. She's professor at the Bioethics Center of Chile's Clínica Alemana, Universidad del Desarrollo. She's the director of the PAHO WHO Collaborating Center for Bioethics at the Universidad del Desarrollo. And during 2014, Dr. Salas was awarded a training program in research ethics at FLACSO with me in Argentina. So I have to mention that. And she's a member of the ethics department of the Chilean Medical Association and a member of the research ethics committee at her university. A pleasure to have you here, Sofía, and your time on. I see you're sharing.
Muchísimas gracias.
Many thanks. Good morning. My presentation will follow the lines of Dr. Siqueira's presentation. I will do a brief introduction. I will do an analysis of the ethics commissions, and then we'll talk about the pandemic. In 2020, globally, we're still talking about an epidemic rather than a pandemic, and then we became concerned about the problems of how do we do research at the same time as we had an emergency in our hands. So how are we going to have informed consent within that context, or how we're going to make testing drugs or drugs under testing become useful drugs that we may use? What were the obligations and the rights of the study subjects, and who were going to be the sponsors, so within their obligations, the sponsors of the different clinical trials, and how we're going to face these challenges. During the pandemic, then we recapped on some learnings when we had the Zika problems within the region, because we started doing clinical trials very, very quickly with new products and with vaccines. It was a need, I would say, because all the alarms went off when we were talking about COVID. We needed to make society aware of why we needed to locally do some research. So our committees and ethical committees needed to ethically review quickly, but also very strictly, everything that we needed to do. So we needed to adapt concerning clinical trials because this new evidence was coming through. The first few trials for phase 3 trials for vaccines, they were aimed at 60,000 subjects. For the 30,000 sample, we already had some evidence, solid evidence. And then in some other respects, we had evidence of uselessness. So we needed to follow the concern in terms of non-validated interventions following Maori protocol, and how could we share data that would be ethical, and how would we share the samples in an ethical way. So we would need to analyze strengths, opportunities, weaknesses, and threats in our SWOT analysis. So regionally, there is a long tradition of research. Most of our countries have a regulatory framework, and we have ethics committees that are in fact accredited. But we have certain weaknesses that we haven't completely resolved to now. We don't work within a network, and that perhaps is something that we should have done earlier on. We don't have updated information concerning clinical trials in progress within each one of our countries. And also, we need multi-peer review, and this sometimes delays publishing the results of clinical trials, but we learned many things from the pandemic, and then we must keep what we learned within the pandemic. We are now and actually acknowledge and recognize the need of our committees, and we definitely decentralize system in order to register our clinical trials. And this is a need. And in terms of threats, I would say that in some countries we still see a lot of red tape for the inner workings of the ethics committees, and there isn't much involvement of the full community when we're talking about research activity. What are the future challenges if we go beyond the pandemic? Well, I would say 3 lessons that we actually learned, 3 key lessons. On the one hand, I'm talking about the how the meetings are going to be. They're going to be virtual meetings, and this is something that is here to stay. But this has actually helped us because it means that we can involve other members who are not on site with us, or we are not regionally with us. We need to reorganize how we work. How do we divide the different types of reviews? We need faster reviews, fast-track reviews for certain projects. So when we get to the meeting, we are more focused. We should actually increase the frequency of some meetings. Once a month, perhaps sometimes is not sufficient. And all the red tape, all the paperwork that we used to do. So now we can make it more agile online. And during the pandemic, we actually made a priority the type of projects that we needed to review. So we had to give priority to those related to the health emergency. And we should be prepared for this in the face of future pandemics. And some of the changes really need new operating or working guidelines review. At the same time, we need to change the way in which we think about the informed consent, because it's actually feasible to use things online, to use the signing online for consent forms. And you could even have all the forms of support. You could record a video, or you could have telephone informed consent. So we have to adapt the concept of the IC signing so that we could allow different types of consent. And then how do we apply all these new forms or templates in terms of the IC online? We could actually need to review the regulation within the ethics committees. And before we have another pandemic, we should definitely strengthen the autonomy and the networked work of all committee members of ethics committees. And we definitely need to better ourselves in the use of information technology tools so we could work faster. We should make it easier for the community to be engaged, and we should make it easier for them to trust us. And of course, last but not least, it is key that different authorities should make work easier within the committees and not restricted. And for this, we have to try and professionalize our committees within the regions with further resources and more time available to us. Thanks ever so much, and Florencia, and I hope I am finishing within time. Thank you, Sofía. I make the most of speaking in Spanish, so I remind you to put through your questions and answers as Q&A function. Please use the Q&A function because this is really important for us and makes life easier for us.
I was saying that please use the Q&A function. It's like in the fourth little screen down. So now it's my pleasure and thanks, Sofía, for being so punctual, to introduce Dr. Carla Saenz. She's responsible for the regional program on bioethics of the Pan American Health Organization, PAHO, OPS para nosotros, which serves as the World Health Organization's regional office for the Americas. She has a PhD in philosophy and is an elected fellow of the Hastings Center. She's responsible for the ethics guidance documents issued by PAHO during the COVID-19 pandemic, including the Catalyzing Ethical Research in Emergencies, Ethical Guidance, Lessons Learned from COVID-19 Pandemic, and Pending Agenda that I mentioned at the beginning. So Carla, the floor is yours. Welcome.
Thank you, Florencia. It's a pleasure to be with you today. And so I'm gonna share with you some lessons that we already had the opportunity to implement during the Mpox emergency. And there we go. So I'm going to talk basically about three specific lessons. One regarding the ethical use of unproven interventions outside of research, what we know as the Muri framework, and also about the fair and equitable distribution of scarce vaccine. And lastly, about the proactive inclusion of ethics in surveillance. And overall, I think we, after the experience of COVID in the region of the Americas, we had the opportunity to plan a greater involvement of ethics in the emergency response. And that was definitely a success, although it certainly revealed some pending challenges. So regarding the ethical use of unproven interventions outside of research, I think that this was, during COVID-19, the greatest ethical challenge encountered in the region of the Americas. PAHO published a Muri guidance in May 2020, but despite that, it was hard. So I think that I presented myself that guidance over 200 times during COVID. And we did revise that version for clarity in the Catalyzing Ethical Research in Emergency guidance that was published in 2022. But the good thing is that during the Mpox emergency, we did not encounter any unethical use of unproven interventions, which in this case are antivirals outside of research. So the one antiviral I'm talking about is tecovirimat, and it was used in the region of the Americas under a Muri protocol. So in adherence with the ethical, relevant ethical guidance. And doing this was an incredible learning process that encountered many regulatory challenges, which highlight the need to take action now with these regulatory adjustments before a next emergency, as Sergio has said too. So the second issue on which we had an opportunity to do better with and implement lessons from COVID in the Mpox emergency was regarding the fair and equitable distribution of scarce Mpox vaccines. So through PAHO's revolving fund, that as a rule procures collectively, transports and allocates vaccines in emergency and non-emergency situations in the region of the Americas, we had to the opportunity to do an ethical distribution of initially 100,000 doses and then 130,000 doses of vaccines to the Latin American and Caribbean countries that requested vaccines. So we came up with ethical criteria to guide the distribution. Primarily wanted to maximize impact, the health impact of the vaccines, for which we had to make sure the distribution will follow the health needs. And then with a view to equity, we seek to prioritize in some way those that were worse off. So that's how the vaccines were distributed. And for example, in the current dengue emergency in the region of the Americas, as you may know, there's a newly recommended vaccine, and even before recommendation, we've been working on ethical criteria for the distribution of those vaccines because, again, we're facing scarcity. And you may not know, but this is just a brief information about PAHO revolving fund that since 1979 has been key making sure vaccines reach Latin America and the Caribbean countries. The last lesson and that from COVID that we had the opportunity to implement in the Mpox emergency is regarding the proactive inclusion of ethics in surveillance. So I think Mpox gave us, based on what we learned in COVID, we managed to be proactive instead of just reactive regarding to ethics. So we issued very brief guidance on ethical Mpox for surveillance, and that was based on the existing WHO guidelines on ethical issues in public health surveillance. But this is probably just an illustration of what happens if there's early ethics involvement in all aspects of the response. So we tried to, the idea was like, let's not make sure, let's not wait till something becomes a problem to think about ethics. Let's just make sure ethics is part of the discussion from the beginning. And I also want to say that I'm talking about these three items, these three topics, as if they were unrelated, but they're not. Because as you can imagine, if you want to distribute vaccines ethically in accordance to the criteria I mentioned, you need data. You need to know where the health needs are, and surveillance is key for that. So it's important, as key lessons, I just want to highlight that we need to act now to prepare for future emergencies, especially regarding legal and regulatory adjustments. And one thing that I think we often forget, and this is what I want to talk about the Mpox experience, we forget that COVID-19 was a pandemic. So it was a national declared emergency in, I would say at least, in all countries in the Americas. So because it was a national declared emergency, health authorities had greater flexibility to overcome some regulatory or legal hurdles. But not every emergency has that magnitude. And Mpox showed us that such flexibility is not the norm. We need to work on the regulatory adjustments and carve the space for the emergency mode for ethics review, as for example, Sergio mentioned, but for any other things too. So as I said, and I'm wrapping up here, ethics is an integral part of the response, and trusted, established relationships with health authorities, with the technical teams in charge of the response are key. And also, as Sofía said, lessons from the emergencies are not just for emergencies. So this work of PAHO has been shared on the chat, and I'm also inviting you to check the site of our regional program on bioethics, where you can join our lists. And thank you very much.
Thank you, Carla. You've been in time too. Thank you. So we have plenty of time for questions, and please do continue sending your questions to the Q&A, preguntas y respuestas, por favor. I will do it in English and in Spanish, and I want to thank a lot Dr. Sara Carracedo. She's helping me with the questions, so you're not seeing her, but she's working hard on the back. Quiero agradecerle a la doctora Sara Carracedo que me está ayudando con las preguntas. Se las voy a leer en castellano.
Thank you to Sara Carracedo. She's helping me with the questions. I'm going to read them out in Spanish and in English. I'm sorry, I wouldn't dare to ask the questions or read the questions in Portuguese. My Portuguese is not very good. The first question, for all panelists, the panel has been very interesting, and this question is very interesting. I have some questions myself about the revolving fund, which is very interesting. It was applied for COVAX. We know there were problems related to COVAX, but that is the first time we started thinking globally. What could we do at this global level? So therefore, that is interesting. There was another question about health emergencies. We know that the impact is larger on some populations, like the elderly, migrants, disadvantaged populations. So therefore, our health public policy should take these types of population in mind, and how can this different impact, this gap could be sorted out so that the impact is not that severe on these populations.
That one question I do have is the role of the rotatory, I don't know how you say it in English,
revolving fund.
The revolving fund of PAHO, which was really an antecedent to COVAX, and I think that it might be working better than COVAX. So maybe Carla can say something about that. That's my personal question to this. But the other question was, health emergencies impact differently on special groups, the elderly, migrants, people living in poverty. So do public health measures need to take these realities into account? And what are the ethical aspects that need to be taken in consideration? I don't know who wants to reply. Sofía.
Well, go Sofía, go Sofía. I was going to talk about the revolving fund, but you go first.
No, es que yo voy a hablar sobre el tema de las medidas restrictivas.
No, I would like to talk about restrictive measures. We thought about that in Chile. We saw that quarantines or lockdowns had different impacts. They had a very hard impact on the population with a lower economic level, because they had to go out and work every day. At the same time, within their homes, they couldn't, for instance, store food as other people with more possibilities could do. Then again, we saw that it had an impact on female workers. Female workers really suffered during the pandemic, and we still have the consequences, the impact of that loss of jobs. So therefore, health is a concern, of course, of the Ministry for Health, but it needs a different, a broader vision, because it had a tremendous impact, economic impact, on the population with lower resources, and also on women, because they were the main carers. They had to look after the kids at home, kids who were not going to school at that time.
Yes. So, and just to say something regarding what Sofía said, we at PAHO were very often contacted to give some ethics input on specifically those issues, and to see what could be done to ensure that the public health measures would not exacerbate existing inequities, or would be really impossible to implement or follow by certain populations. But there's certainly a long way to go to do. I mean, we know we can do better in this regard. Regarding PAHO's revolving fund, so as I was saying, since 1979, PAHO's revolving fund is the main way in which the region of, I would say Latin America and the Caribbean procures vaccines. So the fund helps countries estimate what they need in terms of vaccines and vaccine-related supplies, consolidates the order from all the different countries, so vaccines can be procured in bulk at the lowest price, and then allocates the doses and the purchase order, monitors the shipments, and works really closely with the national immunization programs, which really helps with the coming up with ensuring that those vaccines reach the target populations. And this is how the majority of vaccines are procured in the region. I mean, it's not the only method. There are also a few bilateral contracts, primarily with companies, vaccine companies from the region, but it is it's very important in the distribution of vaccines. And if you think about what it is, I mean, the COVID-19 challenge was, so I mean, if you take global equity between different countries seriously, the challenge from the perspective of the health authority is the challenge of prioritizing the needs of the citizens of other countries over the needs of my own citizens. And it sounds easy to say, but it's a hard pill to swallow. And it was swallowed during Mpox. The distribution of vaccines did not follow the money. I'm talking about the distribution done by the revolving fund. We're talking about a very small amount of vaccines, enormous practical challenges, because I think that as ethicists, this is the thing that we sometimes don't think about. You come up with the ethical criteria, then they have to be operationalized, and then you have to just actually go and do it. And the boxes for each Mpox vaccine box was 4,500 doses, and you just couldn't break it. So it was an enormous lesson that we're already implementing in the context of the current dengue emergency.
So I will profit that Sergio hasn't said anything to ask him a question directly regarding his presentation. So the question is, what does the professionalization of research ethics members mean? And how would this not be contrary to the independence and autonomy of the committees, nor would it generate conflict of interests? And if you want, I can say one thing.
Na minha opinião, em absoluto, não. Eu acho que não. Nós temos várias.
In my opinion, it doesn't. We have different levels of judgments which are more relevant and stronger in terms of results, in terms of rather than ethical assessments, and people are paid, they are remunerated. This doesn't mean that people are not going to be impartial. There would be an advantage, a big advantage. In Brazil, during the pandemic, we held meetings every day, 7 days a week, including holidays, Sundays, and people volunteered, and they had to leave all of their activities behind, professional activities, personal engagements, to dedicate in an altruistic and generous manner to fighting the pandemic. This was very good. It happened. It worked really well. However, I don't think it's prudent for us to depend on the altruism of people, on their generosity. Professionalization would also bring to ethics committee people who are trained and who belong to that area. When professionalization is not key, this may lead the ethics committee to rely on people who are not working or who don't have that kind of training and who have no skill to carry out a good ethical analysis. They may be very able people for other things, very skilled for other activities, but they may approach and join ethics committee. And this makes standardization of criteria extremely difficult. The quality of the analysis may suffer. So I think that professionalization is the way to go. That's what we should do. It's hard work. Oftentimes it's academics, scholars who dedicate their time to an ethics committee. But then their academic activities may suffer. In Brazil, for example, professors who work in graduate and postgraduate programs, they have to produce They have to do research. This improves their assessment and the assessment of the programs where they work. When you work with ethics in research, this does not count any points in your favor. So these professionals, when they focus entirely on ethics committee, they see their professional careers suffer. So for all these reasons and others, I believe there are more benefits than not in professionalizing ethics committees. I don't think this would result in conflicts of interest. Judges who pass judgments on crimes and other issues, they are paid and they're not under suspicion. This is just to give you an extreme example. Of course, the source of funding for that remuneration should be carefully chosen, but remuneration cannot be associated with partiality or conflict of interest. There are ways to mitigate against that kind of influence if anybody should think it exists. In my opinion, it doesn't exist. We cannot establish a direct relationship between remuneration and partiality. I think it's a fallacy. Have I answered, Florencia?
You answered.
Sim?
If Carla or Sofía wants to add something, sometimes it's also said that you are giving a lot of education people that will continue in a volunteer basis, but then it's too much work. They have to continue with their common life and their work and earn their lives. So you are also dropping all this education, all the money you put in that. So sometimes it's also quite difficult. But it's true that it's something quite debatable, at least in the region, no? It's controversial.
Just keep in mind, Florencia, that when we had the regional dialogues, this was the most constant topic, and I feel like we've had like a car that's barely walking, and then barely going, but then you test it in an emergency, and you're like, oh my God, this car doesn't go. So we had a system that was not sustainable, and I think bottom line is also a matter of equity, because we have systems that are designed so only the wealthy can participate in research ethics committees, and that is really not fair.
Yeah. There is another question, and I think this is for Sofía, that asks, how viable is the use of electronic and technological consent processes? What are the challenges that need to be addressed to ensure that consent processes are conducted ethically?
Es una pregunta muy interesante.
Very interesting, that question, because on the one hand, we see more and more media to use it as informed consent, but also we have new ways of researching, because what we are researching is what you have in the network, or on the you have information on the internet as well. So we need to adapt. So we need to have online informed consents that they are going to be equally reviewed, of course. It's just a different format, a simplified format that will allow us to see whether people, subjects decide yes or no, and then they can scroll down, or they will have an openable menu.
Sorry.
So you're answering, yes, you're answering the first part, but I think the idea is more the infrastructure. So it says, for example, one of the biggest issues with e-consent in Africa is the lack of computer literacy, lack of internet, and lack of electricity in some regions. And I was saying just before the panel that on Friday, I was without internet in Buenos Aires city, and on Saturday night, they gave it me back. So it's not just in rural and but it may happen in many other situations.
Y eso fue así además en contextos de
Indeed,
pandemia,
and this is what happened during the pandemic, when we have a health emergency, we have floods or meteorological events, climate events, and then things of more difficult. So let me recap, though, concerning the literacy, IT literacy, as some limiting variable that stops you from perhaps participating in a clinical trial or any other sort of research. The message would be, if I have a population that I want to focus on, are illiterate or they speak another language, as the problem we have in Chile, where we have Haitians, immigration from Haiti. We have facilitators who were able to translate and to collect the data, but collect that consent, that desire of participation, but also to try to adapt the informed consent so the people who are not literate and do not have the right of participation limited, because they should be able to benefit participating in research and to be able to benefit in the last instance from such research. So this is why I think that we have a duty, and our justification also would be to research within these populations and not to use that illiteracy to leave them out. And we must be careful, because they may be saying yes, or they're consenting to, and it's something that if they understood properly, they may say no. So we need to adapt the informed consent process depending on the target population. And of course, if there is no internet, if there is no electricity, this is going to be more restrictive, yes. But this may mean that we have a design bias. If I'm only researching through, let's say, mobile phone, the use of mobile phones, I may be being biased against elderly people who won't have easy access to the use of mobile phones. So this is something that has to be thought through when we design our protocols.
Gracias, Sofía. I have a question for Carla. Could you explain further why is it ethical to provide unproven interventions to people in emergency settings? Isn't it too dangerous?
That's a great question, because in principle, it is not ethical. In principle, so and this is, I would say 99.9% of the cases, we just give people interventions that have been proven. And because they have been proven and they're backed by evidence, we call them therapies. So that's how the world goes. And how do we prove an intervention? Well, we do a study. So in general, you receive either a proven intervention or you're participating in a research study to prove an intervention. So what the Muri framework tries to catch something in the middle that is an absolute rarity that can be considered in an emergency. So if in an emergency there is no proven intervention, no capacity to start research, and there's an intervention that seems to have the potential to be life-saving, you may, emphasis on may, be justified to offer that intervention outside of research, provided a series of conditions are followed. What we saw in COVID is that lots of unproven interventions were given to the population without any oversight, without any justification, and that is absolutely unethical. And that caused not just lack of trust in health authority, lack of trust in health professionals, but it also caused harm. So if in an emergency, we are going to, because there's no proven intervention, no for the population, if we are going to consider and exceptionally, and I want to underline exceptionally offering an unproven intervention outside of research, we have to make sure that such use adheres to the ethical guidelines for such exceptional use. And there are justification, ethical and regulatory oversight, informed consent, and contribution to the collection of data. I mean, you just kind of give something to people, not even find out what happened to them, even if it's not a study. So, and that's what the Muri framework is about. But I really want to remind you that, I mean, we at PAHO have insisted throughout that the main, this is like a little hidden path. It's not the highway. The highway is good clinical trials that will show us really quickly where something, if something works or does not work. And just to give an example, for the use of convalescent plasma. So it was offered under the Muri framework here in the US. Over 100,000 people received convalescent plasma under the Muri framework, and a trial with, I don't know, not even 1,000 people showed that it was not effective. So just so you have a sense of the numbers, I mean, and I have to say that use of the convalescent plasma under the Muri framework was adhering to the ethical guidelines, but still, like, the numbers show you how urgent it is to prioritize well-designed trials with proper controls and rigor.
Well, thanks a lot. We are 3 minutes to finish this session, so maybe we can take just one idea, less than 1 minute, of each of us to close the panel. And I don't know, Sergio, if there's something you want to highlight of what you were presenting, and the same for Sofía and Carla. Who wants to start? Sergio?
Posso começar rapidamente?
I can start very briefly. I think that lessons have been learned. It was terrible. Many people lost their lives. Families were shaken. But it served to show us some ways. As Carla rightly emphasized, we have to be careful always. We cannot allow a new emergency to happen, and it will happen with all the unpredictability that it entails. So we have to ready ourselves all the time. We cannot let things happen to us. We have learned lessons and we have to apply them straight away. Thank you so much for having me.
I'd say that one of the topics I would like to see taken through beyond the pandemic is the possibility of working together with the other RECs so we could have common standards for the review processes. And this was one of our ideas for our vaccination protocols, when we realized that in Chile we had different vaccinations under testing in 3 phases, which meant that we had 20 RECs working on the same topic instead of having common focus. And this is something that we should take beyond the pandemic, we should take forward. Thank you,
Carla.
So we did learn, but what we learned is that we still have to do more work. So many things that we found out that we ought to do cannot be really implemented unless we take action now. And that includes something as simple as Zoom meetings for committees. Some committees found like, oh my God, the emergency, COVID is no longer declared emergency. We cannot, by regulation of the country, we cannot even meet online anymore. So this is like the simplest example to show that we need to act now to not just prepare for future emergencies, but improve the ethics of research in general.
Well, thanks a lot to our 3 panelists, Sofía, Salas, Sergio, Surugi, Carla Saenz. I want to thank again Sara Carracedo, Kevin Childs that was helping us, Catherine Littler that was also organizing all this, and Luis, thanks a lot. I want to recall that you will have the recording available soon in Epidemic, on the Epidemics website. Check for future seminars, and you can also follow us on Twitter, LinkedIn, Instagram, and Facebook. Thanks a lot for being here, and it was a pleasure chairing this panel. Bye-bye. Un placer total y gracias a todos por haber compartido este panel.